Bola Sugala, who is a gynecologist and a great leader in the field of the gynecology and women's heart disease. And she's going to talk about pregnancy and women's heart disease. Thank you for coming, and I appreciate your support. Do not forget to fill the evaluation forms.
Good afternoon. My name is Bola Sogade. I'm an OBGYN talking about cardiology. The topic today is pregnancy and women's heart disease, a unique opportunity for OBGYNs and cardiologists to collaborate. I have no disclosures. And the objectives of this talk is to describe adverse pregnancy outcomes, relations to cardiovascular disease, document adverse pregnancy outcomes in medical record, identify cardiac conditions that negatively impact pregnancy, and refer women with adverse pregnancy outcomes for cardiovascular prevention and intervention. So I have 5 questions. Thank you, Dr. El Shawawi, for inviting me. I put in the questions following your style. So question 1, effects of pregnancy on cardiac disease, true or false? In study findings, women with cardiac disease who become pregnant had a nearly 100% higher mortality rate compared to pregnant women without cardiac disease. Is this true or false? True. And the explanation for this was talked about at the European Society of Cardiology Congress in 2018, stating that women with cardiac disease who become pregnant had a nearly 100-fold higher mortality rate compared to pregnant women without cardiac disease. So just to put things in perspective, what are the top medical causes of death in women in the United States? And we can see in the yellow bubble, we have heart disease and circulatory disorders. And if we look at the very last, just before war, killing women, pregnancy and birth is the other factor just before war. So heart disease and circulatory disorders are a major cause of non-obstetric mortality. So cardiac disease complicates about 1 to 4% of all pregnancies. Maternal cardiac disease is a major cause of non-obstetric maternal morbidity and mortality. Heart disease death rates in women between ages 35 and 54 are increasing, and this includes the women in the reproductive age. Congenital heart disease is now the #1 common form of heart disease complicating pregnancy. In the past, it used to be rheumatic heart disease, and this is still the case in developing countries and in immigrant populations of developed countries. But because of advances in treatment of congenital heart disease, the children are reaching adulthood and they're attempting pregnancy. Also, we see a lot of acquired heart disease because a lot of women are postponing childbearing into the 4th and 5th decades of life. And at this time, they are already with advanced maternal ages and underlying medical conditions like hypertension, diabetes, high cholesterol become common in incidence. Many women develop conditions during the reproductive years that contribute to cardiovascular risk later in life. We have the traditional risk factors, diabetes, smoking, obesity, and being overweight, physical inactivity, hypertension, and dyslipidemia. And we have the emerging risk factors. The fact that a woman delivers a baby prematurely puts her at cardiovascular risk in the future. Also, hypertensive disorders of pregnancy, eclampsia, preeclampsia, gestational diabetes puts the patient at risk of cardiovascular disease and also for diabetes later in the future. Autoimmune diseases, breast cancer treatment with advances in treatment, This puts patients, women are living longer, and this puts them at risk, and also this depression. There are also cardiovascular risk factors that are specific to women. Like I said, the adverse pregnancy outcome, autoimmune diseases, premature menopause, radiation chemotherapy, obstructive sleep apnea, and polycystic ovarian syndrome, which is very common in young women. We now look at the hemodynamic changes of normal pregnancy. The cardiocirculatory changes of normal pregnancy begin at times before the woman knows she's missed her period or whether she's pregnant. So the changes begin as early as the 5th to 8th week of pregnancy, and they peak in the late second trimester. And these changes include the heart rate and stroke volume increase. And this is because of an increased blood volume and increased oxygenation requirements for both the mother and the fetus. The blood volume increases so to be able to provide nutrients to the fetus and to safeguard against the obligatory blood loss that happens during birth. So the cardiac output increases about 30 to 50%. And maternal heart rate increases about 15 to 20%. And the systemic vascular resistance decreases. So we have, because of the increase in blood volume, we have increase in preload, and because of the decrease in systemic vascular resistance, we have a decrease in the afterload. So all of these things lead to a total of about 30 to 50% increase in cardiac output. The graph of the hemodynamic changes of normal pregnancy span from the first trimester to about 6 months after delivery. And the graph is similar to that seen in hemodynamic changes of exercise stress testing in a normal adult, which spans over a couple of minutes. And if you can see from the graphs, a lot of the changes of the cardiac output, blood volume, heart rate, and stroke volume are similar to that happens in normal pregnancy. So that puts pregnancy as an early stress test for cardiovascular and kidney disease. And so here we have a woman that we are performing a stress test on, a non-stress test in which we evaluate for the baby's well-being and maternal contractions. Pregnancy complications, again, could spell future cardiovascular disease. And so during normal labor and delivery, after, towards the end of pregnancy, contractions lead to increased cardiac volume due to increased blood volume. There's also autotransfusion from the uterus, where there's been a lot of blood stored. During labor, there's autotransfusion back into the circulation. So all of this increases the blood pressure, increases the heart rate. The woman is in pain in labor, she's anxious, this increases her sympathetic tone. So all of these things really do put produce some cardiac stress on the woman. And so cardiac reserve in a pregnant woman with cardiac disease is reduced. So factors that encroach on any cardiac reserve must be identified early. So we're aggressive about treating anemia in pregnancy. We minimize pain during labor and delivery. So question 2 of 5, the effects of pregnancy on cardiac disease mortality. Women with cardiac disease who become pregnant had a greater than X-fold higher rate of developing heart failure compared with pregnant women without cardiac disease. Would you choose 60, 80, or 100%? I was surprised to find that in these studies sponsored by the European Society of Cardiology, it was 100% fold higher rate of developing heart failure compared to pregnant women without cardiac disease. So what is the impact of heart disease during pregnancy on maternal, cardiac, and obstetric outcomes? So we have one of the studies by the statewide planning and research cooperative system in New York State. They looked at singleton deliveries between 2000 and 2014. The primary outcome was maternal major adverse cardiac events, a composite of death, cardiac arrest, myocardial infarction, heart failure, and arrhythmia. They also looked at obstetric complications that included antepartum and postpartum hemorrhage, eclampsia, preeclampsia, placental insufficiency, and preterm delivery less than 37 weeks gestation. They looked at 3,878 women with heart disease and 2,280 women without heart disease with singleton births. And they found that 17% had cardiomyopathy, 40% had valvular heart disease, 35% had congenital heart disease, and 8% had pulmonary hypertension. And compared with women without heart disease, women with heart disease had significantly more major adverse cardiac effects. They had more cesarean delivery, they had more eclampsia, preeclampsia, more preterm delivery, longer length of stays in the hospital, and higher hospital charges. So the conclusion for this study is that pregnant women with cardiomyopathy and pulmonary hypertension had the highest rates of major adverse cardiac events during hospitalization for delivery, and that eclampsia and preeclampsia was significantly more common in pregnant women with heart disease, particularly if the women had cardiomyopathy and pulmonary hypertension. So how do we assess risk? If we're lucky to meet the woman before they get pregnant. As OBGYNs, we also double as primary care physicians a lot of the time. So the first thing is to obtain a good history and physical, to do echocardiogram and EKG, and also a brain natriuretic peptide analysis. This is the foundation of a lot of cardiac evaluation in all patients. The BNP level in patients at risk of developing heart failure can be used to exclude decompensation in pregnancy. The BNP levels in healthy, normal women increase 2 times in pregnancy, but they're still lower than the levels observed in heart failure patients. So if you have a normal level, you could use it to, it might be useful in excluding decompensation in pregnancy. From this study, there were 4 predictors of pregnancy-related cardiac complications. Number 1, if the patient had poor functional class, New York Association class 2 to 4, or cyanosis, if they had a previous cardiac event in the form of heart failure, a transient ischemic attack or stroke, or if they have arrhythmia. And number 3, if they have left heart obstruction by the mitral valve area of less than 2 centimeters squared, aortic valve area of less than 1.5 centimeters squared, or left ventricular outflow gradient of more than 30 millimeters of mercury. And also if they have a left ventricular systolic dysfunction with a left ventricular ejection fraction less than 40%. So for each of these numbers, points were assigned. And 1 point was assigned for each finding, and the risk was eliminated on the basis of the sum score. So women with scores of 0 or no lesion-specific risk issues at low risk of cardiac complication and could probably even deliver in a community hospital. So the new things about pregnancy and heart disease, in 2018, there was a CARPREG-2 study, which was basically a model to predict the likelihood of serious morbidity and mortality in women with heart disease who opt to pursue pregnancy. There were 2 large Canadian tertiary hospitals. They followed about 1,900 pregnancies in women with maternal heart disease for cardiac outcomes. And the period of study was from 1994 to 2014. And the aims were to examine temporal trends and identify predictors of complications, antepartum or postpartum, in these pregnant women. The cardiac complication rate was about 16% in the group. And the cardiac complications included maternal cardiac death, cardiac arrest, sustained arrhythmia requiring treatment, left or right-sided heart failure, stroke, or transient ischemic attack, cardiac thromboembolism, myocardial infarction, and vascular dissection. And the bottom line for the study that was concluded in, that was reported in 2018 was that the CARPREG-2 prediction model integrates both lesion-specific and general factors to improve prediction of cardiac morbidity among women with heart disease in pregnancy and in the postpartum. So just looking at some conditions, pregnancy and valve disease in women, bicuspid aortic stenosis. So this is a case study that a 7-year-old woman presented, now at 38 weeks gestation. The OBGYN detected a murmur during examination, and she was sent for an echocardiogram. The diagnosis was congenital bicuspid severe aortic stenosis. On echo, the aortic root was 4.1 centimeters in diameter, and she had mild aortic insufficiency. Our patient was a New York class 1, New York Heart Association class 1 with a very active lifestyle. So during pregnancy, she had monthly echoes that confirmed stability, and she had a normal vaginal delivery with cardiac anesthesia and echo surveillance. So all patients with bicuspid aortic valves, if we happen to run into them before they get pregnant, they should have a pre-pregnancy transthoracic echocardiogram. And if they are asymptomatic, they can actually sustain pregnancy with close monitoring. And the route of delivery is based on obstetric indications. But most women end up having a C-section because of labor analgesia challenges and the detrimental effects of hypotension related to intrapartum regional anesthesia in these patients. And also with active maternal pushing in labor, in the second stage of labor, there's increased afterload. And the increased afterload is contraindicated in dilative and hypertrophic cardiomyopathy or aortic regurgitation. So question 3 of 5, cardiomyopathy in pregnancy, dilated versus hypertrophic. All the following statements are true about hypertrophic cardiomyopathy in pregnancy, except choose one. Hypertrophic cardiomyopathies are usually pre-existing. So is that true or false? Hypertrophic cardiomyopathies are usually unrelated to pregnancy. Many women with genetic hypertrophic cardiomyopathy are symptomatic. So the answer is C, in that hypertrophic cardiomyopathy, they are usually pre-existing and unrelated to pregnancy. Women with hypertrophic cardiomyopathy typically have been diagnosed prior to pregnancy, and many women with genetic hypertrophic cardiomyopathy are asymptomatic, and it can be first detected during pregnancy or shortly after delivery when there's cardiac decompensation secondary to hemodynamic changes. So what are the subsequent pregnancy outcomes in patients with peripartum cardiomyopathy? So published in this January, this past month, investigators used retrospective cohort design to evaluate neonatal and maternal outcomes of all pregnant patients with prior peripartum cardiomyopathy at a single center from January 2000 to March 2017. And the authors provide valuable information for counseling women with a history of peripartum cardiomyopathy. And the data was, how do we counsel women that had a previous history of peripartum cardiomyopathy about their risk of relapse in subsequent pregnancies? And the bottom line for the study was that women with a history of peripartum cardiomyopathy and fully recovered cardiac function with a normal ejection fraction still had a 21% chance of relapse in subsequent pregnancy. And here we look at the pathogenesis of peripartum cardiomyopathy, in which we have, a normal heart, and then there's a pregnancy-associated hypertrophy, and then the activation of protective cardiac cytokines, and the heart returns to normal or progresses to peripartum cardiomyopathy, and then goes on to progress back to normal or to irreversible damage. So apart, from pregnancy, there are other etiologies like prior viral infection, HIV infection, drug induced with cocaine, pregnancies should be discouraged when the women have an ejection fraction of less than 45%. So question 4 of 5, cardiomyopathy in pregnancy, dilated versus hypertrophic. Dilated cardiomyopathy occurring at the end of pregnancy or within 5 months of delivery is most commonly peripartum cardiomyopathy, true or false? So dilated cardiomyopathy occurring at the end of pregnancy or within 5 months of delivery is most commonly peripartum cardiomyopathy. And this is according to an article published in OBGYN News. Other dilated cardiomyopathies that will be encountered less frequently by the obstetric provider include viral cardiomyopathy or alcohol-related and familial dilated cardiomyopathy. So pregnancy and arrhythmia. I have case 2 here in which we have a 26-year-old patient who presents for her first prenatal visit at 8 weeks gestation. Her pulse rate is elevated at 160 beats per minute, and her blood pressure is 105/72, which is the normal. The mean in the second trimester is 105/60. Otherwise, her exam was otherwise normal. So supraventricular tachycardia is the most common arrhythmia of pregnancy. The other arrhythmias that are seen, atrial fibrillation, heart block, ventricular tachycardia, but they're not common, especially if there's no pre-existing heart disease. The management is event monitoring to characterize the rhythm and the frequency. And if everything is stable, no decrease in blood pressure, no chest pain, vagal maneuvers and carotid massage can be initially instituted. And then we've seen the cardiologists use IV adenosine, the metoprolol or verapamil. All these are pregnancy category C. And if they need cardioversion, this can be safely performed in pregnancy. And then pregnancy and coronary artery disease, there's little published information about the optimal management. And patients with this includes patients with pre-existing disease, prior myocardial infarction, percutaneous coronary interventions, coronary artery bypass grafting, coronary artery disease, secondary to systemic diseases like vasculitis. Again, we perform all the baseline tests, including a stress test to rule out active ischemia. Medications like lipid-lowering medications, they're pregnancy category X, contraindicated in pregnancy, ACE inhibitors, pregnancy category X. And so these are to be discontinued. Antiplatelet medications like clopidogrel, they're category B, but we have to weigh the risk of the disease to the risk of bleeding during delivery. In studies, 10% of these patients had primary cardiac events like, cardiac arrest, ventricular arrhythmia, heart failure, and 26% had ischemic cardiac events like progressive angina. 16% had adverse obstetric outcomes, and 30% adverse neonatal and fetal outcomes. Also, there's an early occurrence of metabolic syndrome after hypertension in pregnancy. So there was the study in Obstetrics and Gynecology Journal in 2005, in which the objective was to evaluate the cardiovascular risk profile and the prevalence of metabolic syndrome among women with a history of pregnancy-induced hypertension. They looked at about 3,799 nulliparous women between 1989 and 1997. And the prevalence of metabolic syndrome was higher in the pregnancy-induced group compared with the control. So the conclusion then was that in white women in their mid-30s, the prevalence of the metabolic syndrome is 3 to 5 times increased in those with a history of pregnancy-induced hypertension in their first pregnancy. So this emphasizes the importance of long-term follow-up assessment for cardiovascular risk factors in women. And then the other adverse pregnancy outcomes from chronic hypertension. From the maternal point of view, they could die, stroke, pulmonary edema, renal insufficiency, myocardial infarction, preeclampsia, eclampsia, placental abruption, increased risk of a cesarean delivery, postpartum hemorrhage, and gestational diabetes. And from a fetal and neonatal point of view, there could be a stillbirth, sudden infant death or perinatal death, growth restriction because of uteroplacental insufficiency, preterm birth, and congenital abnormalities also. So, how do we improve, healthcare response to cardiovascular disease in pregnancy and in the postpartum period? So we looked at the California Maternal Quality Care Collaborative that partnered with the California Department of Public Health to produce a toolkit for physicians to improve the healthcare response to cardiovascular disease in pregnancy and postpartum. So the toolkit is free and is available at the website below. And basically, the toolkit consists of algorithms to guide risk stratification and evaluation of women with known cardiac disease or signs and symptoms of cardiac disease. Specifically, the signs and symptoms should prompt evaluation by a specialist as delineated in an algorithm. In addition, the toolkit provides healthcare providers with recommended resources for caring for women with complex cardiovascular diseases in pregnancy, which includes discussion of appropriate contraceptive counseling and information about risk profiles of various cardiac medications. Finally, that document also focuses on racial disparities in cardiovascular disease prevalence and outcome. And why did we look at California? California, because for several years, the US and California maternal mortality rates were parallel. That is, the death to a woman from any cause within 42 days of the end of pregnancy. In 2013, the US rates were nearly 3 times that of California. And after a steady rise in maternal mortality from 1999 to 2006, the rates of maternal death in California dropped, to a low, averaging about 6.9 deaths per 100,000 live births. And this has been sustained. And even despite the, there was a H1N1 influenza epidemic between 2009 and 2010, and California also accounts for 1 in every 8 births in the United States. So they've maintained this lower maternal mortality. There's also a registry of pregnancy and cardiac disease that needs to be discussed. This is an international registry of women with cardiac disease, sponsored by the European Society of Cardiology. Clinicians submitted WHO classification of cardiovascular risk for 5,711 pregnant women from 138 centers in 53 countries between 2007 and 2018. And the most common risk factors were congenital heart disease in 57% of patients, valvular heart disease in 29% of patients, and cardiomyopathy in 7% of patients. Most of the patients were WHO class 1, 21% of them. And in these patients, there were no detectable increase in mortality or morbidity, or just a mild effect in morbidity rate in pregnant women compared to the women with no cardiac disease. However, the worst prognosis was for the 1% of patients with pulmonary arterial hypertension at conception. Their mortality rate was 9% in this patient. And then they also had a new onset heart failure rate in 1/3 of the patients. The next worst prognosis was patients with WHO class 4 maternal cardiovascular risk. This was 7% of the patients, and their mortality rate was 2.5% during pregnancy, with a new onset heart failure rate of 33%. So overall, class 1 mortality rate was 0.2%, and heart failure incidence was 5%. So the incidence of death in all patients in these studies with cardiac disease was 0.6%, and this was 0.007% in women without cardiac disease. The incidence of heart failure was 11%, and this was less than 0.1% in women without cardiac disease. Obstetric complications were the same. The women were all likely to be delivered by C-section, and the fetal mortality was 3 times increased. And premature delivery occurred in 28% of the patients with class 4, compared with 13% of the patients with class 1. So from the registry, the most important message is in recognition and counseling. Women need to know their risks prior to pregnancy. The highest risk was the pulmonary arterial hypertension and WHO class 4 maternal risk. In these patients, pregnancy is contraindicated, and we go ahead and offer them very effective contraception at the same time. Class 4 pulmonary arterial hypertension and left ventricular ejection fraction less than 30%, and New York Heart Association class 3 or 4 was the next high risk. Then patients with previous peripartum cardiomyopathy, severe mitral stenosis, severe symptomatic aortic stenosis, Marfan syndrome with aorta greater than 45 millimeter dilatation, aorta more than 50 millimeter dilatation with a bicuspid aortic valve, and native severe coarctation. These are the risk patients in pregnancy. So question 5 of 5. What is the effect of pregnancy on cardiac disease mortality? Women who had pulmonary arterial hypertension at the time that their pregnancy began had higher risk of A, new onset heart failure, B, mortality during pregnancy, or C, A and B. C, A and B. So the worst prognosis by far was for the 1% of women in the registry who had pulmonary arterial hypertension at the time of conception. For these women, the mortality during pregnancy was 9%, and new onset heart failure occurred in 1/3 of them. And this is also sponsored by the presentation of the European Society of Cardiology. So in the management of the pregnant women with heart disease, we do indeed need to have a multidisciplinary approach. Like Dr. Wegner said, I wish we could have a cardiologist there with us when we're examining the patients and obtaining their obstetric history. So we need the obstetrician, the cardiologist, and the anesthesiologist. Thank you very much.